Puja. I think that.
Good afternoon, everyone. And this was actually a study which our neuro-ophthalmology department has been seeing so many papilledema cases because it's a multi-speciality hospital that I, as an anterior segment surgeon, and I said, let us just study this so that we can give some kind of a take-home or epidemiology to the type of papilledema we have amongst different age groups. So this was basically to study the demographics, etiology, and clinical features of all cases that were clinically diagnosed as papilledema when they came to us. So the secondary objective was to see that are there any differences broadly in any causes between the various age groups, pediatric versus adult population, and to study the variations in the clinical presentation, be it history or examination. So ophthalmic examination or investigations. So it was retrospective, record-based. We took 150 cases, and it spanned over 1.5 years, and it was in a tertiary hospital. The participants, everyone who was diagnosed as papilledema, any prior optic nerve dysfunction, we also ruled out demyelinating disorders. It was consecutive and convenient sampling. All patients had already undergone a detailed history, a good ophthalmic examination, and a neurological evaluation wherever needed. They underwent MRI, lumbar puncture, etc. So diagnostic evaluations meant an entire visual acuity, color vision, extraocular. We actually evaluated them based on these parameters, who came with anterior segment changes, who came with visual acuity deterioration, color vision diminution. Also, obviously the photography was done, OCT was done, and where needed, the visual fields were done. We also made them undergo serum levels of B12 and D3. As I said, we will also ask them about their specific histories. So we saw that among the 150, we had 20 in the pediatric age group, the remaining in the adult age group. Among those in pediatrics, majority were males. And amongst the male and females, there was almost an equal distribution in craniosynostosis and inflammatory disorders, a slight male predilection for infections and tumors. But if you can see, a significant amount of pediatric population also showed tumors as the causes. And of course, the others were inflammatory, infectious, and craniosynostosis. These are the predominant causes where pediatric papilledema is concerned. Again, we see that craniosynostosis is more predominant in the earlier pediatric age group. The infections at both ends of the pediatric age group, and the inflammations and tumors are spread across somewhere in the middle of the pediatric age group. Our eldest child was around 13 years old. So it was from 2 to 12 plus or 13. We had modified this record. Anyway, this is just, I had checked it there, it was showing properly. It is all the 20 children, their diagnosis basically. Sorry about this slide, I checked it there, but it's not playing here. In adults, the 120 patients were divided again with a slight male predominance. Most of the diagnosis went, again, around 30% for tumors, and the remaining nutritional and idiopathic. If we included the autoimmune, the thyroid, and the inflammatory infectious, like TB, meningitis, etc., almost 90% of them were covered. Some were vascular, of which sinus thrombosis, AV fistula, anode carry were some of them. Drug-induced, yes, it was a senior resident from another department. These are the rough MRI pictures. Here you see everything ranging from infection, IIH, there's a midbrain contusion here, there is a sigmoid thrombosis, hyperplasia, there's this thyroid, these are all tumors, right from schwannoma, neuroblastoma, we had a whole range of them. Craniosynostosis would show some sort of a copper beaten appearance and kinking of the optic nerve. Again, these were the fundus pictures, the infective causes, some dysthyroid, these were the infiltrative and the unilateral, some of them local causes, and of course the IH. So when we evaluated them as per their history, we found that adults had more of symptoms like headache, more nausea, vomiting, more than children did. Then, of course, again, this is not showing with the lag of thought. Okay, so in children, the lag of the proptosis was more due to craniosynostosis, whereas in adults it was more due to dysthyroid. And color vision loss was more significant in children, definitely. Gaze deficits and nystagmus more in children. However, visual loss we found was more in adults. Children had more tendency towards hydrocephalus, and adults had more tendency towards a visual loss, again at a higher age. Keratitis again was mostly due to proptosis, and there was a sluggish pupil which was found more in children proportionately. And some cases, one could argue that they were not papilledema, but yeah, they're local tumors, infections, infiltrates, and one had infectious endocarditis due to atrial myxoma, which presented unilaterally or asymmetrically. So we had up to 12 years. Yes, hydrocephalus was more in children. We had a 1:5 infra and supratentorial tumors if we just see the tumors, because they were significant in both sets of population. And visual symptoms, of course, were more in adults. So the pathogenesis is more like when the intracranial pressure increases, there's axoplasmic stasis, which gives rise to the actual optic nerve swelling and subretinal fluid. And the sheath, when it gets distended, there's choroidal folds, and both together may cause venous obstruction, eventually axonal compression and optic atrophy. So in this classification, we had this entire range once we had classified them right from
times up.
Yeah, so we had the entire range, and neuroimaging is important because well, it can show us the entire retinal ganglion cell layer, plexiform layer, and these are the highly elevated OCT, and you can actually see the true axonal edema. So this is just a summary of what I have already mentioned, and the conclusions are that though there were some vitamin deficiency also noted, we need to establish a causal link. Other than this, I've already discussed it all. And we need to promptly diagnose, suspect tumors, especially in both populations. Thank you.
Everything is fine, huge data. But the only point is, I think, the title. It should not have been papilledema.
So it was diagnosed. This is something that we as ophthalmologists or general ophthalmologists, we will say, oh, it's a case of papilledema, sent to the neurophthal or to neuro pediatrics. So, but these finally turn out to be so many different things, especially if they are bilateral. And yeah, you're right about that, because not all of them turned out to be papilledema as per definition.
Yeah,
and I think this was interesting because I think papilledema should have been under inverted commas.
Should have been discedema, unilateral or bilateral. I think that would have been more appropriate term for this study.
Very true.
And you have mentioned that supratentorial, infratentorial lesions are more common in children, and they are more prone to cause your obstructive hydrocephalus. The similar is true with your infective etiopathologies. But I don't know what about your nutritional. 15% you have shown nutritional.
There was a deficiency of D and B12.
Can go to, because if the
maybe needs more study for
the
that.
CSF pressure is more, then it would go into a definition of IIH.
True, but there was an IIH separately, especially with
I've seen that you have mentioned IIH separately.
Retinol for some skin issues.
But that also comes under your papilledema, then your raised pressure, papilledema, nutrition, and IIH.
True, that again becomes almost nutrition.
Thank you.
Thank you so much.